COVID-19 is a huge issue for general population, and especially it is, I think, a huge problem for immunocompromised patients, who are many in especially Western societies, because we have many patients with malignancies, many patients with organ transplant, and also many patients with autoimmune diseases. So a lot of people are in one or the other way immunocompromised. If we remember pathobiology of COVID-19, virus infects respiratory cells. It spreads to the lungs, causes pneumonia that can be associated with respiratory failure. It has some collateral effects like thrombosis that can contribute to severity of disease, respiratory failure, and mortality. And as other viruses, COVID-19 is associated with activation of innate immune response and with activation of adaptive immune response, which consists of cell-mediated and development of humoral immunity. When situation is as in many other diseases, and if the patient is not immunocompromised, healthy immune response to the virus is development, first activation of innate immunity, then development of cell-mediated and humoral immunity, clearance of virus without too much organ damage. However, in COVID-19, we frequently see dysfunctional immune response that is characterized by very severe infiltration and activation of cells of innate immunity, then T cells. It is characterized by widespread lung tissue damage, severe cytokine release syndrome, pulmonary edema, development of ARDS, severe pneumonia, and ultimately mortality in patients with such dysfunctional immune response is worse, and mortality is high. COVID-19 is associated with some autoimmune events. For example, in this study, it was investigated development of anti-annexin A2 antibodies. The study found that patients who had more severe COVID, especially those who eventually died, had more frequent anti-annexin 2 antibodies, which contributed probably to pulmonary thrombosis in these patients. So COVID-19 is associated not just with direct effect of virus, but also with widespread inflammation, activation of immune response, sometimes with autoimmune response as well. Even antibodies that are aimed at neutralizing virus that develop in response to foreign protein, like anti-spike antibodies, are sometimes associated with increased inflammation, like shown here, where serum of COVID-positive patients without anti-spike antibodies did not cause severe cytokine release, unlike those sera that contained also anti-spike antibodies. Some of them increased inflammatory response. So COVID-19 is associated with inflammation, autoinflammation, and speculations sometimes are that dampening this inflammatory response might be translated into better outcomes. So when we look at the clinical course of COVID-19, this severe dysregulation of immune system occurs later during the course of disease, usually in second week of disease, when we actually observe decrease in viral load, but together with development of respiratory failure, we can see in some patients increase in inflammatory response, development of acute respiratory distress syndrome, and progressive respiratory failure. So what is the relationship between immunosuppression and COVID-19? Traditionally, state of immunosuppression is associated with a high risk of morbidity and mortality from infections. However, in previous epidemics caused by other beta coronavirus members, such as the first SARS virus and MERS, immunosuppressed patients have not shown increased risk of morbidity and mortality. And immunosuppression in the setting of hyperinflammation may even be beneficial by blunting excessive cytokine release, or perhaps by preventing autoantibody formation. However, this effect of immunosuppression on development and course of COVID-19 would be expected to depend on type and timing of immunosuppressive medications based on the previous schema that I have shown on time course of clinical picture of COVID-19. So if we again return to the same image, we would expect that people who are on baseline immunosuppression or who have just received immunosuppression just before start of COVID would have increased risk of infection, greater viral load, more severe clinical picture, and probably worse outcome. These patients would be those on chronic immunosuppression or, for example, oncological patients with chemotherapy. On the other hand, during this hyperinflammatory phase of COVID, which starts usually after 7 to 10 days from disease onset, we would expect that if at that time there would be immunosuppressive treatment, that we might see dampening of systemic inflammatory response syndrome, decreased need for ventilatory support, and probably increased survival. And indeed, that has been demonstrated with steroids and in some other studies with JAK inhibitors and anti-IL-6 antibodies. This is published meta-analysis of studies using corticosteroids that clearly demonstrates that use of corticosteroids in COVID is associated with lower mortality. The most famous study with, I think, largest number of patients, among the largest number of patients that has demonstrated this was recovery trial that used 6 milligram per day of dexamethasone, which is medium actually dose, and that has been associated with less ventilatory support and better survival of patients who have received dexamethasone. On the other hand, some other medications, like here B-cell depleting antibodies, would be expected to have a long-term effect on humoral immunity. And while they would not probably lead to increased risk for infection because they don't impair that much T-cell mediated response and innate immune system, they would be expected to lead to lower generation of protective antibodies, either because of either in response to SARS-CoV-2 infection or after vaccination, and they would be associated to lead to longer disease duration, probably because of that, with more severe disease and worse outcome of COVID-19. So how is in real life maintenance immunosuppression related to adverse outcome in COVID-19? Or is it related to adverse outcomes? First, clinical picture of COVID-19 in immunocompromised patients. This is a meta-analysis that looked at various aspects of COVID-19 in various types of immunocompromised patients. Hematopoietic cell transplant patients, solid organ transplant patients, patients with malignancies were included in this meta-analysis, and as compared to the general population, which is in this shown in these boxes. So as compared to general population, immunocompromised patients have less severe systemic inflammatory response syndrome, shown by somewhat lower frequency of fever, and in some studies with a lower incidence of myalgia and fatigue. However, cough and pneumonia were equally frequent. As far as outcomes, again, as compared to general population, hospital mortality was or tended to be higher with immunocompromised patients, especially with patients with malignancies and solid organ transplants, while some of these subgroups had more frequent stay in intensive care units, while others did not have, but such results also depend very much on the healthcare policy of escalating care in different patient groups, and patients with malignancies probably were considered in some of these studies or some of these healthcare systems as patients that would less likely benefit from escalation of treatment than other subgroups of patients. A large population-based study performed in United Kingdom also showed that organ transplant patients with asplenia, autoimmune diseases, and other conditions associated with immunosuppression are at increased risk of dying from COVID-19. But as you can see here, the highest risk of dying is actually related to age of patients, not that much, not to that extent on associated comorbidities or conditions. There are studies that have shown somewhat different results. For example, this study from Italy. Here they showed that patients with rheumatic diseases actually did not have worse outcome as compared to general population in Italian outbreak in 2020. A more detailed analysis, this is a very large international registry analysis, has shown, for example, that when different types of immunosuppressants in patients with autoimmune diseases are concerned, that, for example, anti-TNF inhibitors are not associated with high risk of dying with COVID. Co-stimulation inhibitors have mild negative effect. Anti-B cell antibody rituximab was associated with significantly increased risk of increased mortality. IL-6 inhibitors were in some studies protective. In some other conditions, they did not have negative effect. Well, the effect of glucocorticoids overall was that they were associated with increased mortality. When we think of that, we need to think of difference between the population-based analysis and recovery trial, because in recovery trial, corticosteroids have shown benefit after they were started in second phase of the disease in patients with hypoxemia. In this population, corticosteroids were maintained as background immunosuppression in patients with autoimmune diseases. This possible beneficial effect of TNF inhibitors was also shown in patients with inflammatory bowel disease, in whom TNF inhibitors were shown to be associated with decreased risk of hospitalization from COVID. So maybe there is some role of TNF inhibitors in dampening this early innate immune response syndrome. As in general population, patients with immunosuppression have the same traditional risk factors for worse outcome from COVID, like advanced age, male sex, hypertension, chronic kidney disease, and diabetes. So their immunosuppression adds to this background comorbidity, and these patients really can be rich in comorbidities because frequently they were treated with steroids for a long time. They can be in advanced age, so they have a lot of comorbidities. So what is our general approach to immunosuppression in COVID patients with autoimmune diseases or transplant patients? It is not possible to give a comprehensive overview in such a talk. We always need to follow condition-specific national and international guidelines. General approach is to maintain sufficient immunosuppression to prevent, if this is organ transplant, to prevent organ transplant rejection. So we usually continue calcineurin inhibitors like cyclosporin or tacrolimus. We use low-dose steroids. Sometimes we even increase a little bit the steroids, but we stop immunosuppressants that are not deemed to be crucial at the moment when the patient develops COVID, such in patients with rheumatic diseases, disease-modifying anti-rheumatic drugs, in transplant patients, mycophenolate or azathioprine. And of course, we need to stop or not administer agents that are associated with worsening or prolongation of COVID, or that would lead to decreased humoral response to SARS-CoV-2, for example, anti-B-cell antibodies and cyclophosphamide. In patients who are not on maintenance steroids at start of COVID and are immunocompromised, we still probably should use steroids according to recovery trial protocol, which means this low dose of dexamethasone after 7 to 10 days from start of disease or at the development of hypoxia. And we also can use anti-IL-6 medications like tocilizumab according to the recovery trial protocol, which is again in patients with hypoxia. What is immune response to SARS-CoV-2 in immunocompromised patients? This is a kidney transplant study that showed, similar to some studies in general population, that COVID results in lymphopenia. Total T lymphocytes are decreased in COVID. This consists of CD4 and CD8 lymphocytes decrease, while switched activated B cells and recently activated B cells increase with COVID, leading to humoral response. At least some of this decrease in T cells is because of lung infiltration by lymphocytes. as far as antibody response to the virus is concerned, majority of immunocompromised patients develop antibodies to SARS-CoV-2. These two graphs are from kidney transplant patients, but it has been shown also in patients with other immunocompromised states. A recent study has examined antibody response to SARS-CoV-2 infection in patients with multiple sclerosis. 8 out of 13 patients have developed antibodies, and the only patients who did not develop them were patients who were treated previously with rituximab. So these anti-B cell therapies really can impair response to virus. Another issue in immunocompromised patients is duration of viral shedding. This scheme shows one case of a patient who was immunocompromised, in whom live virus, intact virus, was being shed for 3 months after infection. And they attempted various therapeutic measures without durable response. And besides being associated with prolonged COVID in patients with such long viral shedding, this long persistence of virus in a host can lead to mutations such as shown here, and in some other case reports where during this prolonged stay in the host, virus has acquired several mutations, and some of these mutations could be associated with easier spreading and more severe disease. What is with vaccination? In healthy individuals, vaccination induces humoral immunity manifested by development of neutralizing antibodies, as well, and also induces cellular immunity. But in immunosuppressed patients, we don't know how vaccines will be effective because they were not included in registration trials of the vaccines. And because of that, we don't know what is the optimal schedule and dosing of the vaccines in immunocompromised patients. And unfortunately, there are no published reports of effectiveness of vaccination in immunocompromised patients yet. So at the end, overall immunocompromised, immunosuppressed state increases severity of COVID. Certain immunosuppressive medications, such as low-dose steroids, tocilizumab, possible anti-TNF agents, JAK inhibitors, are or may be beneficial by diminishing hyperinflammatory response to SARS-CoV-2. They need to be applied, if possible, in the second phase of COVID. And also what I haven't discussed, but it is hugely important from clinical standpoint, is the fact that immunocompromised patients are at increased frequency of superimposed infections, bacterial, fungal, and viral, especially if they stay in hospital for a long time because of COVID. And also they have more frequent non-infective complications based on their medical background, such as thrombotic events, cardiovascular events, which all contribute to worse outcomes of immunocompromised COVID patients. Thank you very much.
Hello, thank you for this lecture. I would like to ask you a few questions. The first question is, are immunosuppressed patients candidates for vaccination? And if yes, how long they are protected by antibodies?
They are certainly candidates for vaccination. They should belong to priority groups for getting vaccinated. We have no idea how long will their immune status from after vaccination lasts, because there are no good studies that have examined response to vaccination. So we don't know whether vaccination would be effective enough. We know from some other diseases, like for example influenza, that response of immunocompromised patients is lower in response to flu vaccination than that of general population. In patients that would be vaccinated against SARS-CoV-2, we have no idea how really evidence-based how vaccination would be effective and how long will it last.
Thank you for this answer. I have one more question. This is, what are differences in clinical presentation of coronavirus disease in patients on pathway-specific immunosuppressive therapy and general immunosuppressive therapy, let's say glucocorticoids?
Sorry, what was the difference between presentation on glucocorticoids, corticosteroids versus?
No, I wanted to ask you what is different, which patients have more difficult clinical presentation of coronavirus disease, those on pathway-specific immunosuppressive therapy,
Okay.
or those on glucocorticoids and general immunosuppressants?
Well, I would assume that actually how to say this, the seriousness of clinical picture would be more dependent on net immunosuppression than on particular medication. For example, if you have a patient on low-dose steroid, you would expect that the presentation would be similar to general population. If you have a patient who has just received a high-dose steroids because of treatment of another condition, and then the patient got infected and got COVID, inflammatory syndrome would be blunted, and the progression to pneumonia probably would be faster. If you remember that one slide that has shown the frequency of for example, fever, patients with immunosuppression had lower frequency of fever than general population. So if we would, for example, use anti-TNF agents, like in patients with rheumatic diseases, you would expect to have less fever as initial presentation. So for immunosuppressed patients, we need to always think of atypical presentation of COVID, like for example, with GI symptoms, or patients who just become unwell with development of respiratory failure without this first phase of systemic symptoms.
Thank you for this presentation and your answers.
Thank you very much.
Thank you. So if there aren't any more questions, I would like to thank Dr. Knotek for his interesting lecture. And this ends lectures for now. We will now begin with e-poster presentations. So good luck to everyone. And thank you again, Dr. Knotek.
Thank you.